So hi everybody, and thank you for coming. We haven't done this for a very long time. I'm here just to give a brief introduction to who we are here. This is a membership that we have a multidisciplinary team. This is the champion of our centre here. We have Dr. Kai Brown, Dr. Richie Maher, and others here as well. What we're going to talk to you about is a bit of an introduction on a number of areas. I just wanted to point out a bit of a history. We've been doing this for over 20 years as a multidisciplinary neuroendocrine tumour centre, and in 2019 we became accredited as an international ENET's neuroendocrine tumour centre of excellence. So David was our first PhD student through the program and is now one of our leading researchers in the area. I'm just going to pass this on to David to introduce the rest of the group and the speakers for tonight. Thank you.
So lovely to meet you. If I haven't met you before, my name is David Chan. Together with Nick, we try and coordinate some of the aspects of the neuroendocrine MDT. As I think those of you who've seen us in clinic know, often we look like we're passing the ball to other people. And I think that was part of the point of having this thing and part of the reason I'm really glad we get to chat today, because I think actually we rely very much on our vital team members, some of whom are presenting today, in order to provide you good treatment. I think the vision at North Shore is that we give the right patient the right treatment at the right time. A lot of the scans and the monitoring we do is trying to figure out what that right treatment is and at what time. But I think as we hear from different people today, maybe we can get a better appreciation of that. So I guess we've got 1, 2, 3, 4 speakers, and then a bit of time afterwards for question and answer. Hopefully sort of in a more general sense rather than a specific patient level sense, but maybe some of the new things that are developing, we have some space to talk about that. I'd like to acknowledge particularly Meredith from NECA, who's put a lot of this together, and Miriam, our research assistant, who's organised some of this and also helped a lot with our reaccreditation efforts over the last few months. And of course we acknowledge the land that we're standing on of the Gadigal people. I think without further ado, I should just let people speak rather than waffling on. So I'd like to introduce the first speaker, who's Claire Kent. Claire's known to many of you as the NET nurse based at North Shore. Claire has vast experience at managing patients and talking to patients with neuroendocrine tumours. And one of the exciting initiatives we've had over the last little while is something called the AUSNET trial. So Claire's involved with that, and we thought it'd be great if she could share a little bit, and obviously with NECA as well. Claire, thank you.
So my name's Claire Kent. I'm a cancer care coordinator at Royal North Shore. So I know some of you, and for some people they may have heard my name, but if you're being treated at Genesis Care, you'll know Jenny Arena, who's my counterpart. So that's kind of just to give you an idea of my role. But additional to that, I also do AUSNET trial along with NECA and Flinders University. So that's what we're here to talk about. A trial that's over 2 years with great support from NECA. So just to introduce what the trial is about generally, I know Barbara's here, she's been part of this trial. So one of the theory behind the trial in the first place was saying, well, when patients are coming into a consult, they're often obviously seen by the consultants, talk about scans and treatments and progress and things like that. But what are the unmet needs, the quality of life issues for patients? So this trial is to see whether what ways we can improve that, addressing both the physical and the psychosocial needs of the patients. So that's the background of where we're from. AUSNET is, Royal North Shore is leading it here in New South Wales, but as you can see, we've got Peter Mac in Victoria, we've got Brisbane, we've got Fiona Stanley, and we've got WA involved as well. So, and those are all the leading clinicians and the people involved. And all the background people as well from NECA nurses, as well as Meredith, obviously, but we have Dana, who I'm closely linked with from NECA, and you probably know her as well. and the team from Flinders. We're currently halfway through a 2-year trial. The design is basically to try and capture, well, we will capture 510 patients in total over a 2-year period, aiming at 102 patients per site. Bearing in mind different sites have different numbers of patients, so hopefully Royal North Shore being one of the bigger sites, as well as Peter Mac, theoretically we should capture more, but anyway, we've got a goal in sight. So far so good, I think. We have an inclusion-exclusion criteria. Generally, won't harp on too much about it, but basically we need patients to be quite well and clinically well, a grade, if you understand the grading system, of grade 1 to 3, so we capture a lot of those patients. Obviously more like NEC or large cell, small cell cancers are excluded from the inclusion criteria. We like people, just because a lot of our patients are all over New South Wales, so we want patients to be sort of tech friendly a little bit, so that ideally I try and capture people online, so it saves them visits to Royal North Shore, and we like people to be have a close sort of linkage with their GP as well, because the GP is involved, which I'll talk about in a moment. So the theory behind the project, seeing if we can improve the quality of life issues for patients, and we're trying to monitor those patients over a 12-month period. A little bit busy, this one, but just to give you an idea, basically the patients are sent out, patients are contacted by me, for example, explain about the trial. It's an option, you can opt in or out, there's no issue if people opt out. Patients are asked then, I send them some information, they then do a consent and they complete a patient questionnaire. There then is a computer randomisation. Half the patients will be on the study, half people will be on the arm just as a surveillance perspective. If you're on the study, AUSNET study, then you will have a nurse-led clinic appointment with me and Dana. Well, that means it's basically a telehealth meeting so that we can go through your questionnaire, identify some of the things that you identified, and try and nut out some of the things that people are finding issues for them. That is through a telehealth appointment. It's, and patients are able to open freely about things that are both personal and from a family perspective as well. And obviously we also promote, do you know about NECA, the patient resources, all of those sorts of things. Following the nurse-led clinic, we arrange a meeting with Dana and I, generally through a phone call or a telehealth appointment with the patient's GP, just to go through what we've created in terms of a care plan. And what I mean by a care plan is 3 aims of goals of care that we identified from the questionnaire. So different things that patients might say, this is an issue for me, or this is important to me and this is what I want to continue, because that's still the goal of care. So some people might say, as you know through NECA, some people will say, well, I've got multiple clinical symptoms, I've not seen a dietitian, I've not done this and I've not done that, and I've got nobody to talk to. Somebody else might say, I'm a grade 1 resected NET and I'm fine. But sometimes people are not fine and, they're just mosey on through. And it's sometimes people, those are the sorts of people we also want to capture, because when we're trying to capture people, we want as many NET patients of all sorts of different demographics, ages and stages of disease. So that's what they're, in terms of the long-term goals of the project. Once we've done the GP conference, the patient will be then asked, as will the other arm of the project, be asked to repeat the questionnaire again in 6 months and again in 12 months. We don't have any more meetings or things after that, unfortunately. That is not what's in the programme. Ideally, but we have to follow the arm of what the project actually wants. And the aim overall, the question that they're trying to achieve is, does this nurse-led clinic identifying patients' quality of life issues improve the patient care outcomes in the long run? So that's the aim. That's a very busy form, but basically these are the sorts of forms that patients are sent, including a consent form and paperwork. And I have to also, as well as a patient questionnaire, we're trying to look at what types of medications patients are on, have they had recent admissions to hospital within the 6 months, have they had to had further treatment, all of those sorts of things. Just trying to capture as much as we can over a 12-month period about each individual patient. Nurse-led clinic, basically we try to do the randomisation. The meeting will take, they say an hour, but it varies on each patient and what patient's needs are needed, but we allocate an hour, develop a patient survivorship care plan, as I mentioned, and agreed goals along with the patient so that they have more, like it's an empowerment to the patient as well as to what they want to achieve. Again, a busy form, but basically these are the sorts of forms that I complete. When did they have recent scans, current treatments, and that is updated. That's paperwork that I do every 6 and then 12 months as well to update. So that all goes into a large database at Flinders University. GP conference, like I say, GP, the trial acknowledges that the GP care is so important. And as you can imagine, some patients are very linked with a GP and some are really not. Sometimes I phone a GP like out in Wagga and they have like not an idea of what even a NET is. So actually they're thankful just of a phone call and a linkage to Royal North Shore and even going, what is this? You tell me, what do you want me to do? So the acknowledgement from the study point of view is saying, well, anybody's GP is a primary caregiver. You know, you have to wait for appointments to see an oncologist, but the GP is there on hand, and they are the first point of contact. And what we're trying to see if we can shift some of the ongoing care needs to the GP. That is basically how we're trying to all the details of the study, and GPs are also able to recharge back to Medicare, which helps GPs, so they're getting paid for that conference. And this is like the recruitment flow. So some of the things I've just been talking about, basically new case, diagnosis, MDT discussion, meeting with me, do a consent form, nurse-led clinic opposed to the main arm, just to repeat the questionnaire again in 6 and 12 months. So far, Flinders discovered that we've got good commitment from the nurses that are participating and patient involvement, sufficient data collection, getting GPs interested in the ongoing care of NET patients, high regular central team to help address challenges, and collaborative learning. And obviously it's got a few downfalls, as obviously pros and cons. And one of the main things is just GP engagement, being aware that, you know, GPs are very busy as well, and just getting their GP engagement can be a little bit challenging for different patients and things and their time. But that's basically it. Currently, because I work at Royal North Shore, I've recruited a lot of patients from Royal North Shore. I am going to be recruiting at Genesis, but the issue that I've got at the moment, which is nearly resolved, is access to Genesis database and the medical records and things like that. So I'm nearly there, and so if any of you over at Genesis and you're interested, or anybody that I've missed here at Royal North Shore, I've got a handout and my contact details if you want to participate. That would be great. Like I say, it's trying to capture as many as we can, so 1 more year to go. Any questions?
You said there's 512 people on the program.
Will be.
Will be. How many people is in Australia have got NET?
Over 31,000.
But not everybody is linked to a specialist centre. But a lot of patients, yeah, we have a lot of patients, yeah. So, but for the aims of the study, they want to capture 501, if not more, but minimum.
Sorry, excuse me, the amount of time spent with each patient, is that dependent on the patient?
Yeah.
Or as opposed to, it's going to cost this much, let's slot it in, or?
Oh no, my time's free, so you can have as much as my time as you like.
Okay.
No, but it depends on what the patient's needs are.
Yeah.
So, you know, we're trying to keep to the study purposes. So, you know, that's sort of trying to address the care plan, you know, create a care plan and go through the questionnaire. So trying to keep to the design study.
Slotting in, but you can work around.
Yeah. Some people will look them absolutely fine, you know what I mean, and you know, we can get through it quite quickly. Some people may take the whole hour, if not longer. Do you know, it depends on the person and how much they want to talk and things, what their issues are.
A couple of the slides mentioned a gut microbiome.
Yeah, that's secondary. Sorry, this information's from Flinders. So the gut microbe, basically it was a way that's nothing to do with us here at Royal North Shore, but Flinders are we're doing a study trying to capture as many patients as they can. This was a way that they could capture patients. The gut microbe is trying to basically take poo samples and study it underneath a microscope, which I'll leave to them. And so it was just a way of, because they're linked through the database. So it was an option of patients to be part of that study. I think they've actually got enough patients of what they wanted from that particular gut microbe.
Just another little bit about the microbiome. I think they were looking at 50 recruits and they've got over that. And majority of the gut microbiome is with the NET patients who have been really, really enthusiastic to share their poo. So,
so it's my pleasure to introduce the next speaker, Kai Brown. Kai is a hepatopancreatic surgeon and has significant experience. It's a pleasure working with him, and we've shared many patients together. Kai has trained at multiple places around Australia and completed a PhD. I think it was in lab research to do with colorectal
good
cancer.
memory. Very good memory.
And I guess a question that I think I've talked to some people here about, and you know, surely many patients ask about it, is, well, in this situation, should we not do surgery? When do we do it? What's the evidence for and against? And I'm really pleased to have Kai here demystify it, explain it to us some more. So thanks.
Thanks, David, for the introduction. Yeah, so my name's Kai. I'm a liver and pancreas surgeon. So, you know, I interact and look after patients with NET, both from the perspective of their surgical care from their primary, as well as some of their metastatic disease. That's where it's spread to another organ. And I guess, you know, it's just really, I'm really happy to be able to kind of speak to patients and family members and friends of patients with neuroendocrine tumours because, you know, it's a complicated disease and it's hard to understand. It's hard for us to understand. So I think it must be very hard for patients and their families to understand. This is, you know, obviously where we are right now. And I guess the other thing that I'd like to acknowledge is you know, the privilege it is to be able to work here and all my very expert colleagues who we all, you know, rely on one another. Yeah, I think we've got a great team here. I guess my original remit tonight was to talk about debulking surgery for neuroendocrine tumours and the management of pancreatic NETs. I've actually, that could be 2 talks for each topic. So I've actually just decided just to focus on one to do it justice and answer, you know, a simple question. And, you know, that is, when is surgery indicated for metastatic NETs, predominantly to the liver? I guess to start, I think it's important just to speak out some, say out loud a few key concepts in surgical oncology. So that's the surgical treatment of cancer. And, there are sort of two main tenets in my mind. And number one is that, we use local treatment for localized disease. The local treatment could be surgery, could be ablation, could be liver-directed treatments, but local treatment for localized disease. Each of those have different risks and benefits. And similarly, systemic treatment for systemic disease. Systemic meaning whole body, so things like metastases. And the other main tenet that we generally recognize for most cancers is that there's a proportional increase in systemic disease as the disease progresses. You're more likely to get metastases and spread as the disease is more advanced, higher grade, etc. And then completely separate to that is NETs. They just don't follow the rules of normal surgical oncology. So you can have a low-grade NET which metastasizes widespread early, or you can have a higher grade NET that does not metastasize, and everything in between. And so, it's a complicated area, and it's not a one-size-fits-all kind of treatment approach. The other main thing I think to say out loud is that in neuroendocrine tumors, metastases are common. And in this graph, it's a little bit old, but basically each of those triangles, each of those colors in the pie graph represent, the proportion of primary tumors, and, in the circles, the frequency of metastases for each of those primaries. And in some series, they report up to 90% of patients with neuroendocrine tumors have some metastatic disease, be it lymph node or liver. Liver disease, liver metastases from neuroendocrine tumors are probably one of the most crucial prognostic factors, because it's usually the site where treatment ultimately fails or escapes our control, where we run out of options. And that's irrespective of wherever the net began. So, you'll hear later, through this evening that basically, and this is how I kind of tend to describe it to patients, we've got, for NETs, we've got a lot of tools in the toolbox. We've got systemic tools, SSAs, lanreotide, chemotherapy, PRRT, which is lutate, and we've got local therapies, be that ablation, that could be percutaneous, like through the skin, or intraoperative ablation at the time of an operation, or hepatic artery directed, that's things like TACE, where they inject chemotherapy into the tumor, or SIRT, you might have heard about, radioactive particles into the tumor. We've also got external beam radiotherapy, and of course resection, just another local therapy. So we've got a lot of tools in the toolbox, but ultimately we don't know which tool is the best. We don't know which one is superior. What we do know though is that it matters what sequence we use the tools. Some tools, if we don't use them early, we might not be able to use them at all. And similarly, if we use some tools first, we might not be able to use other tools later. So the sequencing is important. From a surgical perspective, this kind of, I hope, highlights our contemporary paradigm. These are some key questions that I like to categorize patients when I see somebody with metastatic neuroendocrine tumor. The first question is, is the disease just confined to the liver, or is it somewhere else in the body? The second question is it functional? Is there a lot of hormonal symptoms related to that metastatic disease? We know those patients tend to respond differently, but there are also other benefits to those potentially having, local treatment, or even aggressive local treatment, surgery, even if we're not going to necessarily treat all of the extrahepatic disease. And probably the last and most critical question is, what is the pace and grade of the disease? You're probably all familiar with grade. The higher grade, the more aggressive the neuroendocrine tumor is, generally speaking. That's what we refer to as the Chi-67. The pace is another kind of concept. How quickly is the disease evolving, right? So, we might see somebody, and typically for most neuroendocrine patients, the pace is quite slow, okay? So we've got time to observe. Equally, if somebody has a very fast pace of disease, using a local treatment, which maybe has some risk like surgery, is probably less likely to benefit them, because the pace of disease is going to, outrun what we can do locally. The next question is, if it's confined to the liver, is the tumor burden in the liver high or is it low? You might have a liver completely replaced almost with metastases. Local treatment there is not going to be helpful or probably technically possible. Or is it a low tumor burden, okay, where, surgery or another local treatment may be low risk and very feasible to do. And then for patients who have extrahepatic disease, they've got liver disease as well as nodes, maybe they've got bony disease, which is very common. What is the degree of burden of that extrahepatic disease? Is a local treatment to the liver going to be helpful if it's widespread elsewhere, or is it one or two locations? Extrahepatic disease doesn't mean you're not going to potentially benefit from a local treatment to the liver, even if it's surgery. So like I said, there are a lot of tools in the toolbox. The next question is, why would we even consider surgery for NET liver metastases? And before we kind of go into this question, there's some very important caveats. Number one is that all of the data that we have to answer this question is all retrospective. It's based off people who already had the operation, and then we saw what happened, okay? And so there's some intrinsic selection bias. Those patients had the surgery probably because they were going to do well, all right? The patients that weren't going to do well probably never had surgery. So some of that data is a little bit biased. There's no randomized prospective trials, comparing surgery to other treatments, and for like many areas in surgery, there probably never will be, okay? Because it's ethically very hard to do those trials, okay? So it's essentially that's the number one caveat. And the second caveat is the data that we do have lumps a lot of different types of NETs together. Small bowel NETs, pancreatic NETs, they're not the same. They behave differently. So often we're not comparing apples with apples. So there's the two big caveats when we look at what the data says. This paper, which is pretty contemporary, this is the largest contemporary series of patients undergoing cytoreductive or debulking surgery for liver metastases. It's from the Mayo Clinic. It was over 500 patients. And I guess, again, this was retrospective. The main interesting finding was that they confirmed a previous observation that there was a benefit, number one, it seemed, particularly the more you were able to debulk. But interestingly, there was no difference if you debulked 90% or you debulked 100%, okay? 100% is not always possible, okay? And the other main observation was that the biology of the tumor, that Chi-67, the grade, was the main prognostic factor in terms of the survival as well. So the higher the grade, the higher the Chi-67, probably the lower the benefit, although there was still benefit observed. This is an older paper, one that's often quoted, and that's again comparing 90% versus 100% debulking, and essentially they noticed there was no difference between those groups, so suggesting that even if you can get 90%, you're going to get some benefit, okay? And then a more recent paper from 2019, with a slightly higher number of patients, they actually found that their lines crossed over. That means there's equal benefit of over 70% debulking versus complete debulking. So, sort of lowering, again, the threshold of potential benefit for aggressive local treatment for cytoreductive surgery. This was a systematic review. That's basically where you look through all the different papers, all that retrospective bias data, you lump it together and see if you can get a kind of bird's eye view of all those numbers. And this systematic review included 5,000 patients, and a subgroup of those studies compared surgery to some other local regional treatments as local treatments to the liver. And they thought that there was an advantage of surgery over other liver-directed therapies. The second thing is that, you know, contemporary liver surgery is safe. So that's another reason to think, you know, maybe surgery as a local treatment for metastatic disease is a reasonable thing to consider. The other thing that's consistently observed over many studies is that the recurrence rate is very high. Okay, and this is, you know, if I see a patient in my rooms, you know, this is not going to be a curative operation. Okay, the neuroendocrine tumour, if it has the ability to spread to the liver, even if we clear everything that we can see, it's almost certainly going to come back. But what we can do is, by removing all that visible disease, is like rewinding the clock back to an earlier stage in the process. Okay, and I'm going to show you one case example at the end, which highlights at this point. There's always more than we can see on the scan. When I go to do the operation, there's always more tumour there. So what is resectable? You know, this is a sort of exploded blueprint of the liver, and you can see basically, you know, it's a solid organ with lots of pipes in it. The only real limitation technically is that we just need enough liver left over. Okay, so we can do any combination of, you know, one big tumour sitting off to the side, or lots of little tumours, or we might combine surgery with intraoperative ablation to get the things deep inside and therefore preserve normal liver, so long as we have enough liver left over. That's what we refer to as a parenchymal sparing approach. Okay. There is also data out there to say that sort of more aggressive liver surgery techniques, like if there's not enough liver left over, that sometimes we can augment that bit of the liver before going into surgery, make it grow, okay, such that, you know, the function increases, and then the bad bit, when it comes out, you will have enough left over. You know, you might have also heard about liver transplant for neuroendocrine, you know, liver metastases. You know, it's a slightly controversial area, and you know, I have done a lot of you know, transplant training in the past, and typically it's not something that we see in Australia. There are a lot of other issues to unpack there, which I'm not going to go into. What about the primary? You know, if there is metastatic disease, what do we do about the primary tumour? Certainly for small bowel neuroendocrine tumours, you know, there's good evidence that resecting the primary at the same time, even in the same operation, probably confers some survival benefit. The other main, you know, major complication that can happen, particularly in small bowel nets, is some intra-abdominal catastrophe like a bowel obstruction. And if you're caught out somewhere away from a big centre, you know, that can be a very difficult surgical problem for your local country surgeon to manage. Pancreatic neuroendocrine tumours, that question is more complex. Certainly for tumours in the tail, body or tail of the pancreas, then, you know, it's been shown to be safe and probably advantageous to do that at the same time. In the head of the pancreas, it's a different operation, a more complex operation that we call a Whipple. And, you know, in certain circumstances, we can do a synchronous resection depending on the degree of the burden of disease in the liver, or we do it in a staged fashion. You know, clear the liver first, let the patient recover, come back to do the Whipple later on. What about if there's liver metastases but an unresectable primary tumour for different reasons, you know, usually blood vessel involvement? Mixed data, but usually in those patients, you know, if we're thinking about aggressive local treatment to the liver, you know, maybe surgery, maybe something else, you know, we've got an unresectable primary, you know, there are only very special circumstances where we might consider that. Now, what about the higher grade, you know, G3 nets or even neuroendocrine carcinomas? Okay, these behave more like cancers. You know, if it's in a PNET, it's more like a pancreas adenocarcinoma, a pancreas cancer. And they certainly have poorer survival overall. They often recur outside of the liver. And, you know, it's an area where, again, there's only very selected, specially selected patients, usually after a trial of systemic, where we might consider going there, but generally we avoid surgery in those situations. So coming back to this idea of the toolbox and treatment sequence, what tool to use and when? Number one is to get a sense of the pace of the disease. There's no rush. So usually around the time of the diagnosis, you know, I really would not want to consider doing a metastectomy, like a liver resection for patients with neuroendocrine tumor, unless we've observed them for maybe 6 months or more, okay, to get a kind of a sense of the feel of how things are evolving. You know, I guess in terms of the treatment sequencing, you know, at a more advanced stage, if somebody's had years of SSA or they've had some other, you know, liver-directed treatments, you know, sometimes their liver may be in such a state that we can't consider surgery at that time. So it's, you know, in my view, it's kind of one of the tools that we can use earlier on, maybe even again later, but at an advanced stage of the disease, often it's not something that we can deploy. The other important thing I think to think about is in the context of lutate or PRRT. You know, there is a bit of data to say that, you know, if we can debulk the metastatic disease, and then later you have lutate, then you get a higher relative concentration of that radiotherapy in those tumors, okay? Because it's essentially, you know, kind of a fixed dose that's given. If you've got a big lump in the liver of neuroendocrine tumor and you give PRRT, a lot of that treatment is going to get soaked up by the liver. But if we can remove that, you know, then that PRRT will go to other places in the body, you know, bony places, etc., that we can't resect. So I guess I'm just going to quickly go through this case example, which I think highlights some of these issues. This is a 45-year-old guy who we operated on recently, and he had an incidental finding of a low-grade gastric neuroendocrine tumor, and he had large lymph node disease around the critical blood vessels that supply all of the gut and the liver. He did have some mild hormonal symptoms, and he also had a small amount of liver disease. The liver disease was hard to see because, interestingly, it didn't really light up on the dotatate scan. And then at his local treatment centre, basically had 18 months of lanreotide before they started to notice some progression in those large lymph nodes. And then he sought a second opinion here with David. So this, hopefully this works. Yeah. So this is his dotatate scan. You can see those bright spots. That's his primary tumor in the stomach and one of the lymph nodes. And that's the really big lymph node that's right around all the blood vessels. You might catch on the left-hand side, you might catch one focus of DOTA avid disease in the liver there. And that's the only bit that lit up. I arranged for him to have an MRI scan, and actually in the MRI scan, we saw probably 10 separate liver tumours, okay? So much more than what was identified on the CT scan and on the dotatate. They're all kind of small, but not that small. So, you know, sometimes we see this, and interestingly, we sometimes also do an FDG PET, a different type of PET scan. They weren't hot on that either. So given that he'd had relative stability, but now some progression, was hormonally symptomatic, and, you know, was young, with some large bulky lymph nodes, we thought we'd take him, he'd benefit from surgery. And we wanted to try to address all of that disease in the liver. And so some of those lesions you might have seen were on the surface. That's easy for me to remove. Some of them were small and deep. So in order to preserve the normal liver tissue, you know, I got Richie to come along to the operating theatre. He's going to talk to you shortly, and do some intraoperative microwave ablation of those tumours. So this, you know, really illustrates that there's always more there than meets the eye. By the time we got to the operating theatre, we actually found that there was 18 separate liver tumours that we either resected or ablated in addition to doing a gastrectomy and clearing all those large lymph nodes. And this is his post-operative scan, and all those dark spots are sort of ice cream scoops that we've taken out from the surface of the liver, or that Richie's ablated deeper in the liver itself. So, you know, he went home. You know, that we had to do that as an open operation, but he went home on day 6. And interestingly, the gastric primary, when we looked at the whole tumour, actually was a slightly higher grade. All of the liver lesions were low grade. So this is just another example of how NETs behave in a really bizarre way. At the moment, he's continuing on his SSA, but he doesn't have any more hormonal symptoms when he's getting to the end of his lanreotide cycle. So I guess just to conclude, when is surgery indicated for NET liver metastases? In my view, sometimes to cure disease, but more often really to reset back the clock. And how much do we need to, practically achieve? You know, certainly 70, but preferably 90% would be where the most robust data is. Number 2 is to reduce the symptom burden, in particular, from hormonal symptoms. Take the opportunity to treat the primary at the same time, and to really as a preserve further lines of treatment for later, for a rainy day. Okay, later in the disease course. Okay, we can do surgery early and the other things later. Overall, it's a very complicated decision-making process where one size doesn't fit all. And like David said, it's about the correct patient, the correct treatment at the correct time, and in the correct institution, to help navigate this kind of complex web of decision-making.
So we have the pleasure of next listening to Dr. Richie Maher. Richie is an extremely experienced interventional radiologist, and we've had the pleasure of working together on many cases. I think there are 2 accurate things to say about tonight. I'm the least sporty person in the room, and Richie has probably got a claim to be the most sporty person in the room. But I'll let him speak about NETs.
Well, thanks, David. I'll make sure I do a, what would you like, a cartwheel at the end or something, just to show you how sporty I am. Anyway, so I'm going to talk about liver-directed treatments. As an interventional radiologist, I work closely with all the team here. It's a very, close and good team here. Involves many, many different specialties and allied health, and lucky to work here, as Kai said. Obviously, it's a bit of a whirlwind. There's a lot to cover in 15 minutes, so we'll get through what we can, and obviously there'll be plenty of time for questions afterwards. So, when might you actually be referred to an interventional radiologist? Before we get on to liver-directed treatment, your first time you're probably going to see one might be when you need a biopsy. Different ways to biopsy, depends where the primary is, depends where the metastases are. So often it's really important. You may get referred for a second biopsy because you may need, as Kai showed in his case, there was different grades in the one patient. So we always try to biopsy the highest grade disease. So sometimes you might think, why am I having another biopsy? That's often why it might be, that we're actually concerned the way your disease is behaving, that you may have higher grade disease. And that's usually done with ultrasound or CT guidance. It's the same day, usually, obviously there are risks involved, but the risks are usually small. And then basically you may see an interventional radiologist for an interventional procedure. And it's important to note, as Kai alluded to, that metastases are very common, unfortunately, when neuroendocrine tumours present. And up to 75% of patients, may have liver metastases in various studies. The other times you might see us, and that's what we're going to mainly talk about, different liver-directed treatments. The other times you might need to see an interventional radiologist, maybe if you have problems with your biliary tree drainage, and this is particularly in, say, pancreatic NETs, or if you have central tumours which block the bile ducts. You saw that excellent picture of Kai showing the liver anatomy is very complex, and so if you affect the biliary drainage, you may need that drained at some stage. And the other time is, you may have heard of things like celiac plexus blocks. If you're unfortunate enough to have pain associated with where your tumours are, you may get referred to an interventional radiologist. Okay, so look, as Kai beautifully described, which treatment and when is one of our biggest decision making. And like these algorithms, there are plenty of them. This is on the Cancer Australia website, and it just shows you that it is complicated. One of the things just to point out here is that liver metastases, the distribution, as Kai alluded to, it's really about where the disease is and how it's distributed as to what sort of options we can use. And so there are they talk about three sort of types broadly. It's either, basically simple and it's, in one lobe one segment or two segments, and surgery can be an option. Or if you're not fit for surgery, then ablation. And then there are other different types of more complex distribution of the disease in the liver. And unfortunately, the commonest way it presents actually is multifocal in both lobes, which does make surgery not impossible, just more challenging. As Kai alluded to, we might need to do something like the combined approach where surgery and ablation. But each, so it's multifactorial. Individual patient characteristics are vital. So as we've mentioned here, just the distribution of the disease. Is the disease outside the liver? It's not always, obviously if it's defined to the liver, we will try to do liver-directed treatments over systemic treatments, because we just want to hold those systemic treatments back for when you may need them later on in your journey, when you have disease elsewhere. And one of the important things is we look at is prior therapies and your underlying liver function. So you may be, we need to work out, can your liver cope? Can your liver cope with the treatment? We need to leave you with a certain amount of normal liver to survive. So you may get referred to, things like a mebrafennin test, which is a nuclear medicine test, which actually assesses liver function. It's a fancier way of assessing liver function rather than just a blood test. Treatment will be basically, at centres of excellence like here, you should have all treatments available, but there are unfortunately some treatments which are still difficult to get. For example, CERSFIS, which we'll talk about, it's not publicly funded, so there's always an issue of, being able to either pay for it, or if you've got private health insurance, which is awful. We hate having to discuss that, but until we can get it funded, which we're trying to, that is unfortunately the way it is. So the decision will eventually obviously be made, combined decision, and usually from the MDT your oncologist will advise you of what the treatment will be. Okay, so what have we got options? So I'll just go down to, I'm going to talk about intra-arterial treatments and then the percutaneous ablation. Okay, so with the intra-arterial treatments, we've got two main types of treatments. We've got TACE and we've got CERT. Now, TACE, I've also got there, you've got TAE, so they're very similar procedures, except you've got chemotherapy in one and you don't have it in the other. So what that is basically injecting chemotherapy into the artery and then blocking that artery. And we'll go on and talk a bit more about it. CERT is also referred to as TARE, okay? So that's basically injecting tiny radiation, beta radiation, which is labelled to these resin particles, which are tiny and get wedged in the sort of network of the tumour. And then we'll talk briefly about ablation. There are different types of ablation. We're going to mainly talk about what we do here, which is the microwave ablation. Okay, and that basically will go on. It basically causes heating and coagulative necrosis and actually kills the tissue inside you. One important point to note, which people struggle to sort of gather at times, is that dead tissue stays inside you. Whereas surgery, that image that Kai showed, which was really good, on the CT, he's wedging out tissue and ablating is cooking it and leaving it in there. So some people sort of go, well, what happens to that tissue, right? So that tissue dies inside you, and then usually it doesn't cause a problem, but occasionally that can get infected. So that's one of the differences. But it also means that we can't assess the margin very well. Whereas surgery, you chop it out, you look at it, you assess the margin. In the ablation, we just have to try to make sure the ablation zone is wider than the tumour. Okay, so cryoablation is a form of ablation it's basically freezing the tissue. It's mainly used in other organs, not the liver, although it is in some places used in the liver, and it's an excellent technique. And then I've included here, obviously, our radiation oncologists are vital members of the team. They may be involved in focused stereotactic radiotherapy. Okay, so these pictures are not as fancy as yours, Kai, but they basically show the arterial anatomy. On the left-hand side there, you've got what I try to tell patients with all these intra-arterial liver-directed treatments, the reason why they work is that the liver's unique. It's got a dual blood supply. So it's the only organ that's got an artery taking its blood and a vein. So that blue thing is the portal vein and the red thing is the artery. And basically, tumours usually get most of their blood supply off the artery. Okay, and the normal liver gets most of its blood supply off the vein. So that principle enables us to target tumours preferentially over normal liver. And what we try to assess prior to going down TACE or CERT is how vascular that is. So if you're getting 100% blood supply off your tumour from the artery, that's great, because then it's very easy to target it. Okay, all right, so how do we do it? It's, both of these are minimally invasive, like a 2 millimetre nick in your skin, and we go in via the femoral artery or the radial artery. All the arteries are it's like a tree with branches. They sort of connect up. So we have to enter somewhere, and then we have to basically use these things called catheters to get to the tumours. So what's our goal in TACE? Our goal in TACE is to get high concentration of chemo directly to the tumour, whilst reducing the amount of chemotherapy that goes systemically. And that's why we, instead of just giving it to you via a vein, like systemic chemotherapy, you actually get it injected directly into the artery, directly into the tumour. And then it's followed by embolization, where we actually block that feeding artery, which is usually only a temporary blocking, and that way we're actually starving the tumour of blood supply. So we're giving it the chemotherapy, and we're also then starving it of blood supply, an ischemic effect it's called. Okay, and the goal in CERT is similar. We actually go via the artery, but we actually are injecting these radiation particles which emit this thing called beta radiation, okay, and causes a high dose. If you get enough radiation to any organ, it will kill it. Okay, so obviously, and different tissues in the body are relatively resistant to radiotherapy, which I'll talk about in a tick. Okay, so this is just to show you the typical sort of setup. The patient, if it's all a bit too much, the patient is lying down here. Okay, so this is an exposed groin. Okay, you can't see the face of the patient, luckily. And so this is basically this is a C-arm, it's an angio machine. And this thing is how we get our direct X-ray vision, like real-time X-ray vision. It can also spin around you, it can come up to the head, it can go around you. And it rotates around in 270 degrees to give a CT quality image. So you've got on here, is like a CT. So we can get an X-ray image, and we can also get a CT image. And this is what's going on at the groin level. So basically this is a sheath, which is a thin tube going into the artery and the femoral artery. And then we use this sort of telescoping type fashion where you have a smaller tube going inside it, and then through that an even smaller tube. And that can go basically from the groin artery here all the way into the liver artery. This on your right here is an aortogram. So this is an example of the picture that we get from that X-ray machine. You might be able to see here this little white thing which looks like a pig's tail. So it's called a pigtail catheter. So that tube has been inserted from the groin, and we've injected dye. So all the black things that you see there is dye within the arterial tree. So you can see how vascular and how many arteries there are. So this is just showing CT quality image that we can get from that table. And this is how we're able to target the lesion. So this is a lesion here. It's a bright, so this is what we call the arterial phase, going back to that example that I showed you at the start. This is a perfect type of tumour to treat because it's got all of its blood supply off the artery. And this is the portal vein picture. You can see it looks like a black void, right? So that's exactly what we want to see. Enables us to treat it well. Just to show you, this is sort of the standard dosing that we use, doxorubicin 50 milligrams and Lipiodol, which is a contrast agent. That's how I can see it. So we mix that up together, and that's what we inject. And just to show an example of a patient who had, this is a CAT scan. They've actually had a prior resection of a sort of part of the liver from a metastasis, and then they've represented, this is a couple of years later. All these, so this is the aorta here, this round structure here. So this is a CAT scan image. This is white because it's got contrast. So on this picture, on the last picture it was black, but on this picture the whiteness is contrast. And what's white in the liver, so this structure here is the liver, and what's white is tumour. So it's basically taking up the blood supply, and the normal liver is relatively grey, and it's not taking up the blood supply. So this is ideal. It means that we can target this tumour when we go into the artery. And this is an example just before and after in the same patient. This is afterwards. The Lipiodol that we inject is actually a contrast agent, and you can see it on CAT scans and x-rays. So it's very helpful. So we get this roadmap directly after to show exactly where the chemotherapy and the Lipiodol landed, and you obviously want that to match. We don't want that to end up in your normal liver. Okay, so what are the sort of side effects? People obviously, taste. The big thing during the procedure is this thing called carcinoid crisis that you may have heard of. It can occur with any procedure, any surgery. It's basically the surgery can stimulate hormonal production. So if you're someone who's got a functional tumour, it's something that we're always wary about. We make sure we try to reduce the risk by giving you octreotide, and it can give you an octreotide infusion, and sometimes we can do the procedures under general anaesthetic to reduce the risk. And what this can do is, the worst case scenario is it can play havoc with your blood pressure. Okay, that's the biggest danger of it, that it can give extremely high blood pressures. Post-embolization syndrome is common. It's actually more of a side effect because of what we're doing. It will always cause an element of pain and nausea because we're giving chemotherapy, and then we're actually, by embolizing, shutting down that artery, it causes pain. Now that may be 24 hours, but it may be in some people up to a couple of weeks, right? So TACE, and if we're treating bigger tumours, more liver, generally it's worse, right? So that's probably the biggest downside of TACE. Other complications occur, and the other one just to mention, which is rare, is that unfortunately infection can occur afterwards. So rarely abscesses can occur, and patients who've had prior surgery to their bile ducts, such as Whipple's procedures, are at increased risk of that. So they're the type of things we discuss in the meeting: relative risk, what your options are, and try to come up with the best option for the patient. Okay, so SIRSPHEREs. These are amazing, sort of an Australian invention, started in Perth, and basically they're this resin which is, as you can see, very small, 20 to 30 microns, and they have a beta emitter called yttrium-90 permanently bound to it, and so that has a half-life of 64 hours. So when we do, and it penetrates in tissue up to about 1 centimetre, about 2.5 millimetres. So you've got to get it right in the right spot, otherwise, so it causes high dose radiation at the spot that it gets deposited. So we obviously want to get it in the right spot. So I've shown you that image before about the tree with branches, the arterial supply. If we actually inject this in, and it goes into, say, your stomach or your duodenum or your gallbladder, or basically we can cause radiation ulceration. So we basically can cause grief. Okay, so we have to get it very precise. So it requires a lot of meticulous sort of angiography. So it's a 3-step process with CERT. You have a first step would be nuclear medicine consult, where you'll understand and they'll talk about radiation and the principles of it, and you'll actually have some imaging to assess your liver function. That's where you have a mebrafenin test and maybe another PET scan if you haven't already had one. And then you'll come and see me or an interventional radiologist like me for the workup angiogram, and that's where we do the tube and we do a trial run. It's a test run. And we basically inject a mimicker of the SIRSPHEREs, and that mimicker is safe, so it doesn't matter where it goes, but we can image where it goes, and from where it goes we can then work out whether it's safe or not to give it to you. If it's safe to give it to you, we think we can get a good dose to the tumour. We order the dose, comes from Singapore, and then you get booked in for step 3, which is about a week later, and you have the actual, so step 3 for you will feel exactly like step 2. You lie on a table, have an angiogram, except this time we're injecting the real thing and not a mimicker. Generally, and the dosimetry is very complex. Probably fair to say that the take-home message about the dosimetry is that we have come a long way in 15 years. It's now much more accurate It's much more, we try to measure, and there are many more trials which show the dose. We need to get a certain amount of grey to the lesion to get a good response. So we're able to measure, we're able to predict what dose we're going to get to your tumours, and we're also able to predict the dose we're going to get to your normal liver. So we can't go above a certain amount for your normal liver, and we obviously want to get as high a dose as possible to your tumours. This is just to show how the Surspheres comes. It's interesting, it's in a vial, it's in a protected vial, and basically this is called the V-vial, and they're just sort of a cloudy material that we will then inject through the microcatheter placed in a precise location in the liver. So what are the complications? Different to TACE, it's just if they go in the wrong spot, they go into your gastrointestinal ulceration, is mainly the stomach and duodenum. If it goes into your gallbladder, sometimes you can't avoid it. A little bit in the gallbladder is okay. If you get a lot in the gallbladder, you can get a radiation cholecystitis. Worst case scenario, you need an operation to remove it, which is obviously very rare, but something we obviously try to avoid. The biggest thing we fear is this RE-ILD, which is basically pushing your liver too much, the normal liver, such that you go into liver failure. Okay, and that's obviously something we're very cautious to obviously avoid. It's in patients who've got extensive disease who are running out of options, and we're sort of, trying to work out, trying to give you, another option. They're the patients that are at risk of that. And the good thing about SIRT is it's generally much better tolerated, or it's often better tolerated than large volume TACEs. So basically the post-embolization syndrome is extremely rare. So briefly just talk about ablation. I suppose, as I mentioned, there are different types of ablation. Radiofrequency ablation, you may have heard of, has been sort of surpassed by microwave ablation in most places. It's just because it works faster and it's less affected by some of the issues that radiofrequency ablation has been affected by. And just the take-home messages are, it's minimally invasive. It's through, again, no stitches. It's literally through a 2mm nick in your skin. We keep you overnight, but it's generally an overnight stay. So very fast recovery. And as I said before, the actual burned tissue stays inside you. But so what it is, it's basically electromagnetic energy via a generator, which then is deposited in the tissue via this thing called a surgical applicator known as an antenna. It's basically a probe which looks exactly like a biopsy needle. It's about the same size as a biopsy needle, but it's very clever. It actually has water running through it to cool it so it doesn't get too hot itself, and actually imparts heat in a spherical fashion around the tip of it. So that so as I said, the dead tissue is left inside you and not a problem as long as it doesn't get infected. So this is just to show you a final case. This was a patient who'd had prior resections and had recurrent disease. This is a PET scan, and with the PET scans, this is a PET scan on the right, CT scan here. This is a PET CT. We can get this thing called a fused image. So we basically have got this area of recurrence here, which we're able to target under CT guidance. We either use CT or ultrasound. The patient is usually asleep, so they're asleep for this because it can be painful. And we're able to put this small probe into the lesion and effectively ablate it. What are the limitations and risks of ablation? As I mentioned, you need generally, we always like to have an anaesthetist present, and it's either a GA or heavy sedation. So if you're anaesthetic risk, then we can consider sedation, but so generally we prefer to do it with general anaesthetic. And then just not to get too bogged down in detail, but like everything, it comes down to the location of the tumours, the size of the tumours, and where they are. So it's again looking at that distribution of disease in your liver. If it's small volume, there's this sort of magic figure. If it's over 3 centimetres, then the local recurrence rate of recurring is higher. Okay, so we're always looking at that. If it's near central structures, then we're worried about the bile ducts getting damaged. So there are a number of things we have to look at. And as Kai alluded to, it's something we discuss the whole time, whether we're going to do it percutaneously, as in just in the radiology department, or if we're going to do it in theatre with Kai, either laparoscopically or as an open procedure. So I'm always nervous to mention that again, if you've had prior surgery to your bile ducts, then it's almost it's not a definite absolute contraindication, but it's definitely a relative contraindication to having ablation. And that's about it. I think that covers it all.
Thanks very much, Richie. That was super interesting. I liked all the pictures, and I think that sort of brings it home a lot, because I think as the oncologist in the room trying to explain this and trying to draw things with my pen is really hard. So this looks a lot better. I think, look, that's a few of the presentations, and we'll have a question and answer session after this. We're going to have Meredith Cummins, who needs no introduction, to come up and tell us a little bit about NECA before the question and answer time. Thanks.
Thank you for enabling me to be part of this, and I'll also just say thank you to IPSN, who have helped as far as the recording of this session and also some of the food from outside. So I just thought I'd update you on what NECA is up to now. And you had a question before about how many people have neuroendocrine cancer in Australia, and these stats that are showing here are actually the latest stats that came out from the Australian Institute of Health and Welfare on the 8th of October. They were embargoed up till then. So you can see there how many neuroendocrine cancer new diagnoses were projected for that year, or this year, which was 5,719. And all the literature that goes with the data that's there says that NETs is on the increase. But it was interesting because the numbers from last year projected were 5,755. So they're actually down a bit. But their rationale was COVID, because all the dates that they report on are actually a few years behind. So it is on the increase, but it isn't on the increase, but it is on the increase. So I just thought I'd sort of highlight that. So survival rates of NETs is around 48%, and that seems like it's sort of quite low, but that's talking about all the different types of neuroendocrine tumours. So when you have got the grade 3 NETs and grade 3 NECs, the prognosis is a lot worse. So that's sort of where the numbers change.
Is that the 5-year
Yes.
survival rate?
Yes, it is. So in 2020, the projected incidence rate was 21 per 100,000. So we don't actually rank in the rankings, which we actually sort of have said to them that's not really fair, because by 21 per 100,000, we're the 7th most common cancer in Australia collectively for all the different NETs. And they said, yeah, but what we do with the figures is body parts. And because neuroendocrine cancer can happen anywhere in the body, they can't actually put that. So we've just asked, in future, if you do have that number, can you put a little asterisk down the bottom and say, it is actually the 7th most common cancer in Australia. However, because of that, because at the moment, kidney cancer comes in as 7th most common cancer. Previously, it's been relatively even amongst genders, and in Australia, there's a prevalence of 31,380, and interestingly, in New South Wales, the projected prevalence is 10,199. So we're about a third of the amount in Australia. So just some facts, quick facts. One Australia is diagnosed with neuroendocrine cancer every 90 minutes. The average Australian waits for 5 years for a correct diagnosis, and 30% of patients are diagnosed in the emergency department as a incidental finding. As I said, 31,380 are living with neuroendocrine cancer, and the figures there, 5,719 annually diagnosed. 1 in 49 Australians has the chance of developing a NET. 1 in 2 patients are reported originally diagnosed with something else, which we know misdiagnosis is so common. 1/3 of patients report cost as a consideration when choosing cancer treatment, and unfortunately 60% of patients are at stage 4 by the time of diagnosis. So just a little bit of information about Neuroendocrine Cancer Australia, if there's any new people in the room. Our vision is to be champions of early diagnosis and a cure, and our mission is to assist and support patients and carers through support groups and access to networks of expertise such as Royal North Shore. Lobby for access to new and appropriate investigations and treatments, raise awareness and knowledge with the medical community and general public, and encourage and support research in the area of neuroendocrine cancers. So we have the Planet Registry and AUSNET as some of those that we do. So as far as NECA, as we're known as, the patient support, we have NET Specialist Support Service, and we're getting over 200 contacts a month. I think it's actually quite a bit higher. I think we've had some around 400, and it's increasing by about 25% a year. And the Australian Cancer Nurse Navigation Program, of which we received funding at the end of 2023 through to 2027, has enabled us to increase our nurses nationally. So we have a nurse in Queensland, a nurse in New South Wales, a nurse in Victoria, a nurse in Tasmania, and a nurse in WA now. They're not all full-time, but we've actually got coverage there. And we've also been able to appoint a NET counsellor who works 3 days a week with us, and a NET dietitian who works alternate Mondays and Fridays. Those services are all totally free to our patients. With the counsellor, there is no limit to the amount of consults that you can have, but the dietitian, we've set it at 3, and then potentially to go and see your GP to get the care plan, otherwise at the discretion of the dietitian to see patients further. We put together resources such as explainer videos, and we have one on PRRT and familial nets, which was the last one that we did. We run support groups around Australia face-to-face, and also we do national Zoom meetings monthly and a carer support group. Barbara is one of our lovely facilitators for one of the face-to-face groups over at St George. The private Facebook groups have got over 2,300 active members, and we remain the main referral service for NET patients around the country, which is something that will continue to be, especially with the Australian Cancer Nurse Navigation Program, because we're working very closely with Cancer Council and the McGrath nurses to have a really good, robust referral system, and also enable patients to be able to get the specialist care that they deserve rather than just having generalist nurses. So as far as research, we've got the Planet Registry, which we're hoping is going to be resurrected. It has been going for a while now, about 6 years, but it's been really hard. COVID was a real sort of downer for it, and plus the fact that we don't have a lot of data managers to enter a lot of the information. But we're hoping, I've got a couple of clinicians that have thought that they might be able to include it in some studies that they're doing, so we're keeping our fingers crossed. Claire's spoken about AUSNET. There's also a menopause study that we've never had neuroendocrine cancer included in studies like that, so we're really interested to see what the results are, because as we know, flushing can be one of the symptoms that patients have, and it could be attributed to menopause, but we will be able to find out whether there's any differentiation with that. There's a nutrition screening tool which Erin Lang down in Peter Mac has collaboratively created, and we're also doing nutrition guidelines at the moment. And we've also been co-authors in guidance of the use of biomarkers to inform prognosis and treatment for unresected and metastatic gastroenteropancreatic neoplasms, GEP-NETs. And that work's been done with COMNETS, which is a collaboration of Canada, Australia and New Zealand working together. There's a lot of genomic studies that we're hoping can get off the ground, and there's a lot of funding requests for that. David's looking at doing some AI, but NECA is really active as co-investigators and associate investigators, and we're always trying to get more funding for neuroendocrine cancers. And I think some of you would have already heard in the past me saying that the government kept sending these letters from the health minister saying $73 million has been given to neuroendocrine cancer for research. And we thought, it's interesting, and spoke to all the clinicians, and everybody's like, no, don't know where that is. Managed to get a little bit of information, and that was about 8 million that was available. And then we actually investigated further and found out that NH and MRC had been putting neuroendocrine cancers under the same basket or heading as neurological cancers. So it was actually 65 million that neurological got, and we got 8.5 over 10 years. So that sort of really highlighted The government apologised, but they didn't give us any more money. I was just sort of like, how about we sort of even things up? But we're constantly watching what's going on. So as I said, Planet Registry can be wonderful. We're not going to give up on it yet, but it also had an app which you can use to do your quality of life surveys, Bristol Stool Scale, which is what your poo looks like, weekly vitals, and ECOG, so your performance status. And Claire's gone into that. Education, when Claire said that there's a GP down in Wagga who knows nothing about neuroendocrine cancer, we've got RAC GP accredited education for healthcare professionals. It started off as a GP project, but we've included it with all healthcare professionals who've got an APRA number, and we're up to 4,557 HCPs who have completed that around the country. We've had funding for a one-off for national awareness campaign and patient resources, which we're continuing on with. We do a lot of in-services online, which is free education sessions for HCPs, nurses around the country. We've got the NET Patient Education Program, which is Living with NETs, and we run 3 programs per year. It's 2 hours over 4 weeks, and it's been really, really successful. We do a lot of conference presentations. I spoke about that before. We're going to put together some diet education modules once we've finished the nutrition guidelines. We do forums like this, and you can't quite see it at the bottom, but there's the Will Norman Nurse Education webinar, which a patient who was in the UK, he's in his 40s, died of a neuroendocrine cancer, and his father and sister live out here in Australia, and they're actually funding one of our positions. But one of the requests was that we would do education for Australia and UK nurses. So we put together a webinar with UK, New Zealand and Australian nurses. We had patients presenting their cases, and it's been really successful. I think we had 47 online to do it, and we're planning another one in March next year, which will be on treatments, carcinoid syndrome, carcinoid crisis and carcinoid heart disease. We do a lot of advocacy work. We've got our National Action Plan, the Optimal Care Pathway. We were stakeholders in creating that with David as the lead. And the quick reference guide we have found to be extremely useful. A lot of our patients, when we did the awareness campaign, were ringing us up and saying, well, they weren't our patients then, but saying, I've got these symptoms, what should I do? So we actually got them to take the quick reference guide with them to the GP so that they knew what tests to order, so that they weren't having unnecessary tests done, and it's continued to be really successful. And we did a Senate inquiry submission and provided evidence on the 1st of February down in Melbourne. Oh, I'm stuck. No, back. A little bit more advocacy that we're doing. So PBAC, which is the Pharmaceutical Benefits Advisory Committee, we do a lot of consultations, and at the moment we've submitted for cabozantinib, and what we've heard, it will hopefully be through before Christmas, so it will be another medication that will be good for NETs. The Medicare Medical Scientific Advisory, so Medicare things, we are always putting in submissions to try and get better investigations and rebates and everything for patients. We did the VHL von Hippel-Lindau petition to the House of Representatives and got 17,803 signatures in 4 weeks, which was a record. Belzutifan was, for von Hippel-Lindau patients, was put forward with a PBAC submission. We did a parliamentary event on the 4th of July, and it was successfully put onto the PBS on the 1st of December, which is the first time that it had actually been, the request had gone in. It came into Australia in 2021 through the TGA, was made an orphan drug. There was no submission made to PBS or PBAC. So once we sort of found out what was happening with these patients, we really pushed for it, and it came off really well. Currently working with the bridging funding lobbying. We're also collecting lots of patient stories and interviews. We're doing forums. We did one in Adelaide this year and Sydney, this one, and Canberra and Perth next year. And on Thursday we're holding a parliamentary event for the Senate inquiry, because we got the Senate recommendations through in May 2024, and it took 458 days before the government actually responded to it. So we are taking that to the government and talking about it and seeing what they're supporting in principle, and noting and what they're actually going to do about it. As I said, National Awareness Campaign was a one-off payment, but we're now doing a lot of fundraising to do that. And as you can see, there's a picture of David when he was on television with Michael Usher, which was fabulous. And through our liaison and everything with Michael Usher, he's actually become our ambassador. He has nothing to do with neuroendocrine cancer before, but I was at a function and I stalked him, and he was quite happy to actually sort of become our sponsor, so not sponsor, ambassador. Yeah. As you can see just at the side there, with our neuroendocrine cancer awareness, with that neuroendocrine cancer frequently camouflages itself as something else, and so you need to think it's not just black and white. There's a lot of grey areas there. So. And this was one of our patients down in Melbourne put this together, that because we were the Unicorn Foundation, that's got the unicorn horn at the front there, and the minibus, and he said, you're driving your own bus, you can have on your bus who you want to have, and you can kick off who you don't want to have. So that's our little unicorn bus, and you're driving your own bus. So thank you so much.
Hopefully this is a helpful session for everyone. I think it's about 7:34. We're running a little bit behind. I apologise. So for the next 25 minutes, we are here at your disposal. We will give you answers that will try and be honest, may include the words I don't know or we need to know more. But really we are here to try and, I guess, answer some of the questions, whether it's to do with one of the talks or not. And really I'd like to throw it open to you guys, and we'll try and allocate to the most appropriate person for each question.
So the first question is to Kai, and it's, can you identify a primary just by looking at it when you open somebody up? And the second question is probably to David and Nick. I was going to ask Rory Clifton-Bly, and it's, what's the relationship between faulty BRCA genes and pancreatic neuroendocrine cancer?
We'll ask Kai for the first question.
Figure out the answer to the second.
I think you both run.
So I guess to answer your question, I mean, most of the time we have an idea where the primary is based off the preoperative imaging. And certainly for pancreatic neuroendocrine tumours, that's, usually there's a lump, There is an exception with for very rare gastrinomas. So gastrinomas can be very tiny. That's a special subtype of neuroendocrine tumor that makes a hormone called gastrin. They can be very hard to find. We usually know that they exist because of the effect of the hormone. Okay, so that's one thing, and the way if we haven't identified it on the preoperative imaging, they're usually in a few common places, and intraoperatively we use like maybe an ultrasound to try and locate it. Okay, so that's for pancreatic primaries. For small bowel primaries, it can be different again, and small bowel neuroendocrine tumors have an interesting characteristic that they're often multiple. So, there may be a lump that we can see on a scan preoperatively or just by looking at it. But sometimes you can have nodal metastases, right, which we know are dotatate avid, that they look like neuroendocrine tumors, but we can't obviously see the primary in the small bowel. The primary might be tiny, like a grain of sand. Okay, so you might not be able to see it just by looking at the bowel. And in those cases, you often need to feel the bowel with your hand because it's usually hard, and feel the rest of the small bowel for other primaries. So sometimes yes, sometimes no is the answer. Does that answer your question?
I guess I was asking, for example, if there are two tumours on the pancreas, and one has been more FDG avid, but the other actually looks nastier when you open the person up. Which would you say is the primary? That's sort of...
I mean, I think, usually if there are two tumours, we'll be able to see which one's which and know which one, anatomically corresponds with like the FDG avid one. And I'd probably, you don't look at it and go, oh, it just looks a bit ugly. Probably the FDG avidity gives us more information about the biology, what's happening at the cellular level, So it's there's not one superior measure. It's a put all that data together to get a whole like comprehensive picture of what's going on.
I might start, and David can perhaps add on to this one because I don't think we know the answer completely. Pancreatic neuroendocrine tumours are associated with hereditary syndromes, the commonest ones being multiple endocrine neoplasia and VHL, one of the ones that Meredith showed one of the drugs for. BRCA is more commonly associated with more solid tumour malignancies in breast, but you can get others, ovarian, prostate in men, whether it's BRCA1 or 2, colorectal cancer, as well as some other tumours. I'm not sure of the specific association with BRCA impairment with pancreatic neuroendocrine. I'm more so with others, but there are some other DNA repair genetic abnormalities that are prone to produce pancreas cancer, but not so pancreas neuroendocrine cancer. And I think BRCA is more on the line of the pancreas cancer line than in fact pancreas neuroendocrine. But David, do you want to add to that?
Yeah, super interesting. I agree with Nick. The most common genetic syndromes that have to do with pancreas neuroendocrine tumours is the ones, the men ones, the VHL, those things that we've talked about. When they did a big study looking at pancreas neuroendocrine tumours and the genetic basis of it, this is really back 7-8 years ago, it wasn't one of the main pathways they looked at. But we know that actually some of these neuroendocrine tumours do have BRCA or sort of something in that sort of pathway, things, relatives of BRCA, mutations related to those. I guess the question for me is, look, firstly, is it hereditary? I think we need more evidence, more research to say, do BRCA patients, are they more likely? The ones with the breast cancer, are they more likely to get it? Probably, big evidence at the moment. The second super interesting thing is, okay, so those patients with BRCA and breast cancer, or pancreas cancer, right, the classic one, you sort of you're starting to see some particular medicines that you can use for those patients that other patients without the BRCA, they don't have, mismatch repair, they're called PARP inhibitors, for example. Like, is there a potential role for those patients, in this particular setting? So if you have a neuroendocrine tumor and you have a BRCA mutation, like, could it be in the future that we can see some of these drugs being used? Really, I think that's interesting, but we really need a lot more research on it to find out.
The more genetic analyses we do of cancers, the more we might find the associations. But that's part of going forward now.
Okay. You mentioned how important it is, the initial grading of the tumour. Does that grading evolve over time, or does it need to be like reassessed or regraded?
I'll start again. So the longer the evolution of the disease in the patient, the more that it can change. Generally, we think a patient with a low-grade tumour will have a low-grade trajectory. And there are some patients who will maintain that and outlive the disease because it's behaved in an indolent low-grade fashion. But we've shared many patients, often pancreas patients, who have disease that is apparently behaving differently in the patient than the rest of their disease. And we see that, and these are the kinds of tumours that we may ask Kai to say, can we cut this out? Because this is what we call discordant biologic behaviour. You take that out and you find the Ki67 is no longer 5% as it was in the original, but that particular clone is now 30 or 40%. So there can be evolutionary change, not necessarily across all the tumours in the whole patient, but can be in part of the disease. And so when we monitor patients, we tend to use dual PET imaging, both FDG PET, gallium-68 PET, and I guess take a step back, and that's what the MDT does. We rely on, and Richie and others, and all of us having a look at the tumours and saying, this biologic behaviour is different. The patient's not behaving like a grade 1. Something's changed. So there can be evolutionary change, even though in some patients that may not happen, and they may continue in a slow trajectory for the rest of their lives and outlive the disease.
Yeah, I mean, I would say that what you're kind of alluding to is that, is the label that you get labeled with at the beginning, does that stick? And the answer is no. It can change, and it's important to, for the MDT process to have that broader perspective that, okay, well, this isn't, something is changing here, something's evolving. Does that, it's not a one size fits all. Does that one lesion, maybe there are a few lesions in the liver, but this lesion's getting bigger, the others are staying the same. Maybe we need to pounce on that lesion because there's a clone, a cell in there that's undergone some sort of mutation where it's now no longer responding to the treatment that you're already receiving. So, it's not a static process. You have to be kind of dynamic.
It's probably worthwhile to say, I think, for me, thinking about NET, sometimes there's a lot of unknowns and that creates uncertainty and anxiety. So I agree with all the things. It's probably worthwhile saying that something that's really, really slow, something that's a true grade 1 and you've biopsied it and you're pretty sure it's slow, it usually doesn't go from 1 kilometre an hour to 100 kilometres an hour. Over time, it can go from 1 to 5 to 20 kilometres an hour. It can speed up a bit. But usually these things are very different to the true, really high grade, grade 3, poorly differentiated things. There seems to be sort of like a speed limit these things hit, and it doesn't go to the other group of things that you hear about that get treated with chemotherapy. So a really interesting area. So yeah, no, thanks for the question. There was one in the back. Oh, I'll go around. You can stay. I'm getting my steps in.
Thank you. My question, you may have partly answered it, but my question is, in connection with grading of NETs, what is actually being graded? What qualities or aspects of the tumour can contribute to a grading, and what do the different gradings mean to a layman?
So you're describing the growth pattern of the tumour. So there's two forms we look at. One is called mitotic rate, when you look at the tumours and how they're splitting and look at the growth fraction and how quickly they're multiplying. And the other one is Ki-67, which is a protein score. The higher the Ki-67, the more likely that there is a multiplication in the tumour. The higher the mitotic rate, the more likely there's growth. And we take the higher of the two scores. They're not exactly homologous, but we take the higher of the two scores as what is the final grade. And there's a classification the World Health Organization gives, grade 1, 2, 3, and then there's the cancer, which is on the right-hand side of the spectrum. And based on whichever is the higher of the two scores is what gives rise to the grading. So it's actually undertaken under the microscope. So that's actually looking at the morphology, how the cancer looks. And then the other way we judge the biologic behaviour of the tumour is over time, and by looking at imaging, mainly functional imaging. David's done some work, leading work in looking at combining PET scans, and I might let him talk to that.
Yeah. Can I bore you by talking for half a minute about PET scans? Okay. PET scans, there's too much information, and partly part of the reason we want to write grants is to understand it better. It's like a CT scan on steroids. There's more information than on a CT scan. But I'm very simple. We're all very simple, except for interventional radiologists who know a lot, and surgeons who know a lot about anatomy. I'm a simple guy, right? Like, is the thing bad or is it not bad? So really simply, if the tumor is really, really bright on the dotatate PET, this is probably a slow thing. If it's really, really bright on the FDG PET, that one's not to do with whether it's neuroendocrine, it's just to do with is it fast moving or not, just to simplify it. That's kind of bad. So if you think about really slow tumors, they should be bright on the first scan, the one that tells you it's neuroendocrine, the sort of slow stuff, and not bright on the second scan. If you have really fast stuff, it should be bright on the second scan, not on the first scan. The medium speed ones should be bright on both scans. So some of the research, I think, is not just me, I think some people in this room, some of the nuclear medicine people, we've been working together on over the last 5-10 years that we're fortunate to get some funding for, is looking at how do we make sense of that? On a very simple level, some of it is saying, okay, maybe if you've got something that smells a bit suspicious, something that's faster, maybe you've biopsied the good thing, you haven't biopsied the thing that's a bit faster. Well, if you've missed something that's fast, maybe you should treat it differently. Maybe we should ask Richie to biopsy it. Maybe we should ask Kai to cut it out. you know, maybe we should watch it closer. Maybe we should use more aggressive treatment. So some of the things I think that it's really been really nice to work on is, I think some of you in the room, I've talked to you about, we don't know what to do about this PET scan and that PET scan, no one can agree, to try and put some data behind it and understand it better. Because I think we use more and more PET scans to image things. But how do we interpret the changes, and can we use it to predict how the tumour's going? So it's not great. When we talk about grade, it is the biopsy bit. But I think the research question we're trying to lead the way on is, can we use scans to predict grade, to sort of virtually go, oh, that bit is a bit faster, that bit's a bit slower. Or even if you can't prove it, that bit's a bit suspicious, you could look at it quicker. I could talk for all day about this. Sorry, I'll stop talking. Yeah.
To discuss the MDT, why do we have an MDT? Because we don't know the answers to these questions. When we see a patient for the first time, we're trying to make a judgment on what we think the journey will be like, but only time confirms what that journey is like. We use the tools of the trade, as David says, the grading, the PET scanning to try to predict what will happen, but it's only over time that we actually get the answer to that. And when we present the cases to our MDT, people like Richie and our nuclear medicine physicians looking over the scans over the long period of time, we really get the true understanding of the natural evolution of the disease. And many a time, if you're experiencing with the disease, you'll see a report that says there's been a change, and we go over the scans over time. So another reason, there's actually just some fluctuation in a lesion over time. It's not that bad. So it's not an easy decision. That's why the MDT is so valuable to us. But I don't think we can make decisions in one point in time. It's a journey, and we have to see, and we have to identify when we're worried about something to act on it, and when we think, no, we're not so worried about that, I think we can wait.
Fantastic. I'll take the next question. Thank you.
Rory.
Oh, sorry, to introduce Professor Clifton Bly, who's just come from another meeting. He wasn't ghosting us, I promise. So no, thank you for joining us. And we're just doing question and answer, so thank you. Hi, sorry, please.
Hi, good evening. Just to follow on with what Dr. David was talking about, scans and changes in tumours. I was diagnosed 6 years ago as a grade 2 gut primary. At that time they found that I had an umbilical hernia, and a little tumour had poked through there, and I could feel it under my hand, and it was about the size of a pea. That is what they biopsied and told me I was then a grade 2, relatively slow, KI less than 5%, and that sort of went fairly well. It was resected. My hernia was fixed. It wasn't. It failed. And recently had 3 cycles of lutate, finished that in 2023, stable for 2 years till May. So that came up this year. The tumour in my navel has regrown, and it was 1 centimetre, and most recently, so between May and sort of September, it has grown to 1.7. So David was saying that on scans they watch the progression of tumours over a long period of time. What happens when it's over a very short period of time? I was very interested in what Richie was talking about with the ultrasound, because I can, it's right there. I can feel it. It's right under my skin. And I thought, oh, maybe I should just get that done. And then I thought, no, maybe I should go see Kai and get that cut out. So, I've got a whole team there. What happens when something grows that quickly and it's kind of giving a lot of pain but everything else is still stable?
I'd be referring you to Kai, I think.
Did you want to say?
I'm happy to, but you can go first.
Yeah, I mean, I think, I guess, I think it's important just to speak in general terms. And like I said in my talk, an important consideration for me is getting a sense of the pace of the disease. And the pace can change over time, and in the same way that the grade can change sometimes over time. A change in pace doesn't necessarily mean there's a change in grade. And, we're monitoring all of these things, along the way with scans, sometimes with rebiopsy, etc. Sometimes, a local treatment may be required for local symptoms, and, maybe that's an independent consideration from the global course of the disease as a whole, where it is in the burden of disease elsewhere and the pace of disease elsewhere in the body. So, and then for a local treatment for local symptoms, whatever that might be, that's a balance of risk and benefit. Okay, so I think, all of those things are considerations. And in my mind, because neuroendocrine tumor is, it doesn't follow the rules, like I said, you've got to have a sort of a flexible mindset to sort of see each case on its own merit. That's, I guess, what I'd say about that. David?
I'll be seeing a surgeon on Thursday for his opinion. But, I'm a bit loath to undergo that.
I hope that it gets better. I guess thinking about some of the general principles here, we think about, I guess, a few things. The word oligo, like oligarch, means not very many. Not one, but not 15. So where there is something where most of the disease is well behaved, but one spot is a bit more oligoprogressive disease, then you're like, oh, actually zapping that bit, whether it be zapping it with radiation, zapping it with surgery, or microwave, or, whichever way it may be, that's not wrong. If something's really painful in one spot, then you're like, oh, dealing with it probably improves quality of life. Like, stuff the scan, like the scan's important, but if you're suffering and there's a way to make that better, well, why not, right? It's not just about tumor control, it's about quality of life. And then you'd say some of the cool stuff we're trying to push at the moment is, okay, if 99% of the tumors can be treated with lutate, but two of the things are not treated with lutate, if you look at the trials and you look internationally, people wouldn't treat it with lutate because they're like, well, we wouldn't treat all the things. But I think some of the conversations I've had in clinic are like, well, okay, but why can't you just zap that thing with radiation or with liver? And so I think this is trying to refine that flexibility, trying to add to that flexibility that Kai was talking about. In one sense, we want to give general principles, because if we just said everything is case by case, that doesn't build confidence. You don't feel like we're being systematic about it. But when you see these principles being applied consistently, that's where you'd say flexibility meets the expertise of the team. Yep. Yep. I'll get.
You've got to get your steps up.
I am getting my steps up. Hello, sorry.
Well, Nick and the whole team have been looking after me for 15 or 16 years now. Thank you very much. And I think I've played all the games. Yeah, I have. My question is, what's coming up in the future?
You can all do some. Well, Rory, from an endocrine point of view, we can go. Yeah.
An endocrinologist has a relatively small part in the neuroendocrine tumours unless they're functioning and producing hormones. So from the endocrinologist's point of view, we are getting more tricks to be able to control the hormones that neuroendocrine tumours produce. So sometimes they're problematic in and of themselves. Serotonin is the one that everybody's familiar with from small bowel neuroendocrine tumours, and things like telorostat have been a useful addition to our armamentarium in addition to the somatostatin analogues like lanreotide and octreotide. From my point of view, the hyperglycemia has been quite problematic. Our ability to control hyperglycemia has been difficult. So insulinomas, particularly when they're metastatic, are difficult to control. And there are some new drugs coming down the pipeline to block various modes of insulin-mediated hyperglycemia. I think I'll throw to the other members of the panel. I think possibly the more exciting things on the horizon are the alpha emitters for peptide radionucleotide receptor therapy. and some of the new chemotherapeutic agents, and also potentially immunotherapy in selected circumstances.
So I'll talk briefly about some drug therapy, and we'll go through some of the disciplines here. So in the low-grade neuroendocrine tumours, there are new drugs. So you've heard cabozantinib is going to be approved. There are new generation drugs such as those. We'll be running a trial here on campus of one of those new drugs against a comparator. As Rory alluded to, there's new forms of PRT or radionucleotide therapy. Lutate's an example of one of those. We actually had an alpha therapy trial ready to start a month ago. I might say it openly in the forum here, the company pulled the pin on that globally because the market's too small and they wanted to run it in prostate cancer. That devastated a few of the patients we had on the list for going on to that trial. I think that'll come around again. There's other companies investing in alpha therapies, and we will hopefully get some new opportunities there. And in the higher grade disease, there are more immune-based therapies targeting pathways that are shown to be effective in what's called small cell lung cancer, which has been a case example, terrible disease that we had very limited options for. High-grade neuroendocrine cancer behaves very similar to small cell, and there's lots of drug development in that area, and Boehringer Ingelheim actually has a drug that we're going to be doing a trial with in the near future. So there's new drug development to try to treat and modify the disease. I'll pass on to surgical and we'll move
Thanks.
on.
I think from the surgical side of things, what's happening sort of now and into the future, I think there's two elements. One is, I guess, surgical technique and the delivery of surgical services. And what we've seen, like, I'm a liver surgeon and pancreas surgeon, what we've seen for those operations over the years, is the safety of those operations dramatically increase. That's partly to do with training and minor issues to do with technique, but a lot of it is to do with centralization and, those operations being performed by surgeons who do them every week. That's all we do. We don't do a couple of pancreas resections a year. We do, 100, and so on and so forth. And even with the bowel surgery, bowel surgery for neuroendocrine tumors is complicated, particularly with the lymph node metastases, and not all bowel surgeons operate around those blood vessels where the lymph nodes are. So part of it is the recognition that the outcomes and safety profile of surgery for neuroendocrine tumors is improved with centralization, with high volume, and yes, with different surgical techniques. And what that does is it actually means if it's safer, then the risk-benefit equation for that particular local treatment is more, it actually expands the opportunity for more patients to actually have that type of treatment. Okay, so that's number one. Number two is how surgery. When I talk to the medical students, I sort of say, "Oh, what is surgery? Is surgery, knives and forks and cutting things out?" I mean, a lot of what I actually do is think about the tumor, about the cancer, about what are the alternatives to surgery. How does surgery dovetail with systemic treatments? So, what is happening in the non-surgical space directly impacts what happens in the surgical space. Because if you look at, say, a completely different scenario, let's talk about melanoma, right? And this is kind of some broad statements. I mean, I don't treat melanoma, but the advent of immunotherapy in melanoma has been revolutionary. And there are some patients, for example, that have metastatic melanoma. And, some of those patients are having really long, it's just dissolving away. But for some of the lesions, they might become resistant. And so for those patients where we would never consider, an operation, now we're going back to the drawing board and going, well, maybe there is an indication for surgery because of the changes in systemic treatment and other targeted treatments, for that tumor line. And I think the same will be true probably in neuroendocrine as these other treatments come through the pipeline.
Oops, sorry. And I'll try not to repeat the things that have been said before. I agree with all of them. At the same time as progress taking time, I think true progress always takes 3, 5, 10 years, you know, from something starting to something becoming mainstream. That's true. Every silly article that comes in the news, most of them are like, oh, this is interesting, but what they actually mean is it might be on the market in 8 years, which is not very helpful, honestly, for our discussions. I think it's really important that we recognize actually there is progress being made. So I think, for example, Meredith alluded to there's a drug that is potentially going to be funded in the next few months, you know, fingers crossed, which would be nice because we've got the trials, but it's to do with the approval process of these drugs like cabozantinib, you know, going through the process, patients, advocacy organizations pushing forward and saying, no, this is really important. Because if someone like me writes a statement, they'll say, oh, that's nice, but he's just a doctor. He doesn't know anything. He doesn't live at the coalface. And this is where we really need your help together to get those things across the line, because your voice actually honestly counts for more than mine when it comes to pollies and votes and political influence. The second part related to that, before I talk about the science, is participation in trials. I think every time I talk to a patient about a trial, it goes something like this. You should feel fully free to involve yourself or not involve yourself. I will look after you the same whether you do or not. That's true on the micro level. On the macro level, we try and advocate. I think a few of us have advocated and saying, Australian patients are really keen to have access to all the same trial treatments that overseas patients do. Please try not to discriminate against us because the drug takes a bit longer to ship, because you think our patients, there's not many patients, because what we say our patients are highly literate, highly organized and highly motivated. There are less competitors here just because of the way drug development often centers around the US and Europe. If there is something that is right for them, they will be very willing to consider it. So I think as much as, you know, the correct line on a one-to-one basis is decide whether it's right for you, these are the things that will continue increasing the access to patients, to trial medicines for patients, as Nick has alluded to, because that's, I guess, how some of the trials think about, oh, Australia is a small place. We have to navigate the regulatory mechanisms here. Is another country we have to do, it's more effort, then we have to do the time zones. So I think, look, that shouldn't be a barrier, but you can see how sometimes it's just a little bit that tips you over and across. And so this is where I think if we all work together to say, no, we're motivated, not going to promise people and put their name on a list and force them, but actually if it's the right thing to participate in these things. We are having some new imaging trials that we're sort of homegrown at North Shore over the next little while, whether we can do 2 PET scans on the same day, that'd be cool. One more day to play bowls or go to the opera or whatever you want to do. You know, can we do fancy things where we can do both scans together? So those are things we've gotten like approval for in the last few weeks, and we'll just try and sort of identify the right patients, you know. So I think those things, AUSNET, yeah, they're not new drugs, but actually all of those are ways we can work together in trying to understand more about the tumours. Big picture, nuclear medicine, new PET scanners, alpha therapies, as Nick was talking about, new ways to use lutate better. We're currently suggesting a trial concept called Coronet, where we're trying to add chemotherapy together with lutate. Hopefully that will be something that we can launch, because we're really interested in does it make things better? Because really, I think the reality is we don't have 15 drugs all for the same condition. Each one of those doesn't work for nearly as long as we want. We're here to work with you to try and make that better. I'll stop talking. Oh, yeah, of course.
Thanks, Frank. Thank you. My wife diagnosed with NETs last December, and we're going through the paces, as everybody said, trial and error and what's in the toolbox, so we're very grateful. I see you guys all in the front line. So how do you move forward by consolidating all this information to speed up research? We were another hospital. I had no idea about this stuff. So we're so grateful that we found Nick, we find you people, listening to you guys. I don't see that, I think. So how you've been on the front line, being so busy, how does research get accelerated to consolidate all this information and start moving forward? That's my question, and what we can do to help.
I might kick off this one and pass it around if that's okay. I think I'm not an isolated body. I think I've worked with these guys, and I think, you know, I've learnt from each of you, and I think particularly Nick supported me a lot, but really all the people here have helped us grow a group. I think the question was really, how do we contribute to research? And actually, I think there's a side question there. How do we improve practice through research? You know, because, yeah, research paper, whatever, but how does it actually make our treatment and the treatment in the other centres better? Is that right? So partly is the research, but partly is the dissemination, the translation of the research. So I think when we started, I was the first neuroendocrine fellow here. We didn't really have a massive research. And this is back 15 years ago. Now we've got PhD students. I've had a postdoc. I actually work 3 days a week for the university, so I'm fortunate enough to get funding from the national and the state authorities, which comprises part of that total that Meredith was talking about. And with that funding, we've managed to hire people to really try and do some of that research, in which case, rather than us being the boots on the ground, we can start to exert more of an influence. We do go to conferences. I apologize, I went to a conference last week, but part of the point is to build the links, to share the information with other people, because you're sort of like, the first step is to talk and convince ourselves as a group that's the right thing. Then you'd say we should convince the other centres in New South Wales and Australia that's the right thing, but that's too small. If we've really found something that's universally applicable, that's why we go, you know, really each March to go and talk to the international NET experts to work together on projects, to work together on guidelines. So right now, you know, we've got that one on the biomarkers, how that should influence treatment, working on one looking at PET scans, how do you interpret one PET scan to the other, and such projects. They're not new research, but it's part of the important work you alluded to. Once you know the research, that's not enough. You have to then try and come up with ways where you don't overstate it. You're not saying everyone has to do the same thing, but you say, based on the evidence, maybe we should all do things this way, and I feel moderately strongly based on this paper and this paper. So I'm fortunate to get a bit of funding through the collaboration here to do that, but I think we all are interested in the research and in improving. That's why we're here, I think, to talk about it. Richie, thoughts?
Oh, I just think you hit the nail on the head. We're all time poor. And like as a proceduralist, you know, have very little time for research, but we're always interested in trying to do it. So we are involved with research projects, but we don't have enough dedicated time. Yeah. No, it's a very good point.
One of the things we're, as a centre of excellence, one of the reasons we pursued that and are trying to continue to maintain that, we're in the process of reaccreditation this year, is because it sets a standard. And Kai alluded to it earlier in terms of surgical standards, and the same thing applies to interventional radiology standards. The more you do in a particular area, the better you get at it. And what you need to be able to do is publish what you're doing or present what you're doing, and that you need time for, as Richie said. As a Centre of Excellence, we're not actually funded by the government specifically for that purpose. We've done that because we, as a collaborative group for all the disciplines, think it's the right thing to do. And fortunately, our current CEO is actually giving us some funding to be able to go through the process. What we're trying to lobby for is the state government to recognise that if we are a Centre of Excellence, then we probably need to have some specific funding for some of the things that are done here, like LR surgery in specific areas, interventional radiology that we do in nuclear medicine and imaging and endocrinology. That is above and beyond what the norm does. And then you set a standard. We can't look after every patient around the country, but we can offer advice. Then if we're funded, we can get extra people in the different subspecialties, and then have that little bit more time to report on what we do and why it's better to do it this way than before. So where I'm going to suggest we seek some help from you is in terms of government lobbying, because we've done our own lobbying to New South Wales Cancer Institute, and there's no specific funding for it. But this hospital is a state centre for for spinal injuries, for example, burns. They don't do the same thing for cancers per se, and this is probably an opportunity to do that. And NeuroEndocrine is an example because the whole of Europe does it that way. What that means is we want to get specific funding. Peter McCallum's the other area in Australia that's similar to us. Because beyond that, it's just us advocates passionate about what we do, doing the work, but not having the capacity to report on everything that we do, etc.
You go first.
was just going to quickly say, as far as patient advocacy or non-government organisations such as NECA, we work so closely with all the clinicians around the country, and I mean, it is your stories, it is what's happening with you that's so important. And when we do go to lobby, the politicians want to hear the patient stories. We always go with them so that they can get the other side of what the organisation can do or can't do, and so we really need to work together to get that information out there and lobby state and federal MPs. I mean, they have no idea at all, and the more that we get in their face, the more they're going to actually listen to us and start to notice us and get more funding. And I know NECA, sort of with the international groups and everything, they're actually amazed at the amount of inclusion that we have with all the clinicians around Australia, and just being part of it and helping build the study protocols and everything, just to be there to say whether consumers, you know, is this going to be a benefit? Yeah.
I was just going to say, as an insider looking out to oncology, I think there have been 6 revolutions for modern oncology care. The first is the role of highly targeted local therapies such as surgery or the interventional radiology. The second is the application of radiotherapy, internal and external. The third is the rise of genomics and the important role of molecular therapeutics. In neuroendocrine cancers, less relevant because the molecular landscape tends not to lend itself to specific targeted therapies, although there are certain select instances where that applies. The fourth is the very important role, which has been alluded to, the multidisciplinary nature, and just the implementation of multidisciplinary clinics has been transformational in modern oncology care. Just in itself, getting people with diverse expertise in the same room has improved outcomes. And I think that's the essence of a centre of excellence, is having people of diverse expertise, each contributing towards a patient-focused outcome. And I think that needs to be emphasised, because we often like talking about omics and machines and expensive radiotherapy, etc. But sometimes just the simple fact of getting people into the room on a weekly basis can be very important and powerful. The elephant in the room, which again I think will probably be the most important aspect of modern oncology care, is the role of AI. This is very rapidly becoming implemented in modern clinical practice, and it will be through the Centre of Excellence where it's best applied. So it's being able to capture very big data sets and using computers to analyse the data to say, you've got a different pattern to you, and so we need to treat you this way, and we need to treat you in a completely different manner. And AI will be best implemented through centres of excellence, because we'll have the biggest data sets and be best able to implement the advantages that we can leverage off AI.
Thanks. If there's one more burning question, we might have time for it. We're a little bit over time otherwise. Yep. Okay, one last one. That's okay.
Thank you. So these are kind of 2 questions of a similar type, but if you're able. The first one is, when do you recommend genomic studies? And the second one is, can you speak about the role of histotripsy? I heard that it might be coming to Australia.
Mm-hmm.
I'll take the histotripsy.
Yes, so genomics can be applied to the tumour or the patient. So particularly for pancreatic neuroendocrine tumours, somewhere between 5 and 10% of people will have an underlying heritable susceptibility to neuroendocrine tumours, most commonly multiple endocrine neoplasia type 1, but other genetic syndromes as well. We can usually recognise that either on the pattern, multiplicity or family history of the circumstance. Tumour genomics, again, I'll hand over to Nick, who's more of an expert, and David, who's more of an expert in tumour genomics. But we know quite a lot about the tumour genomics of neuroendocrine tumours. It just hasn't yet translated to therapeutic improvements, in my opinion. But Nick, you might have more.
Oh, I would just echo that exactly. We all are advocates for wanting to get more information, but it's only as good as what you can do with it. And sadly for neuroendocrine tumours to date, it hasn't really transformed into applications in terms of targeted therapy. But there's still an importance in looking at it. So, for example, as I said, there's some advances being done in the high-grade stakes now, looking at some forms of immunotherapy, and there's some lessons being observed in other tumour parallels there. So, yes, it hasn't been transformative there, unfortunately, but it doesn't mean we shouldn't keep exploring opportunities.
I'm going to embarrass myself by saying something not in my field of expertise. Histotripsy seems to be very hip at the moment. You know, I think I've gotten at least 1 or 2 questions about it a week, so I think it's definitely the press is there. When I come up with a new word, I try and put it into a bucket, because the question is, what kind of therapy is it? And then once you know what kind of therapy it is, actually it follows to know, well, what situation should we use it in? As I understand it, you know, having had a look around both the marketing and the literature behind it, it's really a form of high intensity focused ultrasound at one particular area. So the idea is, using a specialized machine, you give a lot of energy into an area to try and kill the cells, which is cool. It's nice to have a different way to do that. But then you'd say, what classification, what type of treatment it is? It's a local treatment into one place rather than a systemic treatment. It's a treatment into one place that gives a lot of energy to try and kill it. In which case, where it slots into the things we've talked about is actually into what Richie said about local treatment, isn't it? Liver-directed therapy, microwave ablation, killing this thing, or I guess thinking about radiotherapy. Some way of killing the cells in just one spot, or 2 spots, or 3 if you're being fancy. Therefore, it is well suited to, if you've got 1 thing or 2 things that are superficial, that are targetable by it. You know, I'm not the expert on it, I don't use it. But you'd say, okay, if you've got something that's in 5 places and there's growth in 5 places, maybe that's not the best option. And so that's usually how I try and deal with a relatively new concept. It is interesting. Certainly the machines seem very expensive. It would be, how do I put this? Not here, overseas, the amount being charged for it seems to do more to do with trying to get enough return on investment to justify the cost of the machine, rather than honestly being sort of titrated to the amount of benefit that it has over other mechanisms. New things are cool, but we need to show that they're better than the old things in order to be able to charge premium. So I think as it comes to Australia, those would be the things I'd want to talk to my patients about. I'm not trashing it. I'm just saying it has to prove to be superior to something else if it's going to be charging more than something else. I think that's a general principle, or it has to be less side effects or something. So be really interested in how the data is. I thought most of it's to do with non-NET tumours rather than NETs. The more data we have, the more we can evaluate, is it sensible for patients, you know. Hope that made sense, sorry.
Thank you.
Yep. It's 8:20. We have overstayed our welcome. I'd really like to thank particularly the speakers, to Meredith, to Miriam in the back, who's also organised things from the local end, to Ipsen, who supported this event, and I guess particularly to you guys for making the time and conversing with us. We'll try not to do the next one in another 4 years, we promise. So no, hopefully this can be a semi-regular thing where we can just have a bit of a chit-chat, and, you know, hopefully that helps you as well, you know, through your journey. Thanks very much.
Thank you.